Good afternoon all. First of all, I'd like to thank the organizers of PodCon for this wonderful opportunity. So I'll be speaking on the steps of filler splitting. So a brief word about proximal humerus fractures. It is a third most common fragility fracture. 10% of fractures usually occur above 65 years and 70% occur above 70 years. So it is a fracture of the older age groups. And 80% they are undisplaced or stable and can be managed conservatively, and 10% of them they are displaced 3-part or 4-part fractures. So a brief word on anatomy that will help you in plating. So there is a neck shaft angle of 120 to 130 degree, and you should you see that the GT tip is 8 mm from the superiormost part of the articular surface, and there is a retroversion of the humeral head, that is 18 to 33 degree retroversion in relation to the transepicondylar axis. So regarding blood supply that we need to know when we plate, the most important supply is the anterolateral ascending branch of the anterior circumflex humeral artery, which runs along the lateral aspect of the long head of biceps, that is the lateral aspect of the bicipital groove. So this is important because you are placing the plate just lateral to the bicipital groove. So if you injure this vessel, there is high chance for AVN of the humeral head. So the newer studies have shown that the posterior circumflex also gives 64% supply to the humeral head. So this is you can see the anterior ascending branch of the anterior circumflex humeral artery, that is the arcuate artery that is just lateral to the bicipital groove. So there is 97% risk of ischemia with a combination of less than 8 mm extension of the head into metaphysis, more than 2 mm middle hinge disruption, and anatomical neck fracture, that is the Hertel's criteria. So you take home point is you protect both circumflex arteries and you avoid dissecting the medial metaphyseal area. So the other anatomical landmark that you should know while plating is the axillary nerve. You see that the axillary nerve winds around the shaft, accompanies the posterior circumflex humeral artery. It winds around the shaft of humerus at a distance of around 3.5 cm from the GT or 5 cm from the tip of acromion. That is the landmark for axillary nerve. So what are the indications for fillers? So usually you do fillers for 50 to 100% displaced surgical neck fractures, in displaced 3-part fractures, valgus or varus, in displaced 4-part and fracture dislocations. And what are the contraindications? Usually undisplaced or minimally displaced fractures we can treat it conservatively. In head splitting fractures, so should see for head split in your pre-op X-rays or CT scans. So head split can be posterior split, it can be anterior split, it can be both anterior and posterior with only the central part articulating with the glenoid, or it may be a burst fracture. And in anatomical neck fractures, and also in when the articular surface is more than 40% involved, this you can see anatomical neck fractures where only a shell of bone will be there and it is difficult to get a hole for your screws, and in fracture dislocation. These are all contraindications for fillers. So is fillers a simple procedure? So review shows that fillers is associated with much more complications than plating elsewhere in the body. There are 33% complication rate for fillers, and out of it 46% they are related to the implant. And out of the implant complications, the most are screw perforations. And it is more in older females and more if the GT is poorly reduced. So coming to the steps of fillers plating. So first step is how to know your instruments. So you should have all the instruments ready. You should have your retractors, you should have reduction tools like levers, ball spikes and reduction clamps. Should have your KYs to reduce the tuberosities and reduce your fragments and fix it. Should have your fiber wire methibond to get tension band sutures on the tuberosities and secure it to the plates. Should have all lengths of plates available. And one thing to remember is that should have a processes ready, because you may miss a head split fracture in a pre-op CT scan and you will have to convert a surgery to a processes. So you should always have a hemi replacement process or a total shoulder process ready before going. So you should know your fillers plate. The screws from A to E, they are accept 3.5 mm locking screws. There are 10 suture holes in the periphery of the plate. There are 2 holes for guide wires. And the most important screw is the screw number E, which is the calcar screw, which the screw is infromedial, and this protects your calcar and it prevents for future varus. And there are distal combi holes that will accept both locking screws and conventional screws. And standard plates 3 to 5 holes, and long plates we are also available from 5 to 12 holes. So step 2 is how to position your patient and position the C-arm. So usually you use a standard radiolucent table. So ideally it's a beach chair position, but usually you won't get a beach chair in our institution, so you'll have to adjust with a supine position, and you will place a folded pillow under the interscapular area, and the scapula is at the edge of the table, and Siam can come from the top or can come from the sides. So one important thing to remember is that you should check that you are able to get adequate Siam views before scrubbing. You should have at least a AP view and a axillary lateral view. So how to get adequate exposure? So usually the three approaches are there, and the workhorse is the deltopectoral approach. So we all know the internervous plane, it is between the deltoid and the pectoralis major. Usually your cephalic vein guides you in your plane. In some conditions you will find it difficult to find the cephalic vein, so you can look more proximally where there is a muscle, where there is an area that is devoid of muscle tissue, and you can trace from there downwards to see the plane. Usually the cephalic vein has got more tributaries towards the deltoid, so you retract the cephalic vein towards with the deltoid laterally. So the advantages of deltopectoral is that you don't need to identify the axillary nerve, but the difficulty is that you are opening it anteriorly and you are trying to reduce a GT that is posteriorly and laterally. So it is difficult to reduce a GT by going the deltopectoral approach. And also it is difficult to place the plate in the lateral position. And as I already told, it is higher chance for injury to the anterolateral branch of the anterior circumflex humeral artery, that is the arcuate artery. So the advantages of, we can go the other approach is the anterolateral acromion approach, where the incision is in the anterolateral corner of the acromion, and you split between the anterior and the middle fibers of deltoid. So the advantage is that you are going laterally, so it is easy to see the GT fragment and easy to reduce the GT fragment and easy to place a plate also. And it respects the blood supply, and usually we use this approach for minimally invasive surgery. But the difficulty is that you are opening laterally, so it is difficult to see the anterior part, so it is difficult for intra-articular reduction, and if you want to convert it to arthroplasty, it is difficult. So other ways to ensure adequate exposure they are, you can do an intrafracture exposure. You can mobilize the fragments and you can reduce the head through the fragments. You can put a subacromial lever, you can use a subscapularis peel. So this is a tendon, subscapularis tendon is stripped from its insertion in a lateral to middle fashion, and it is reattached by bony tunnels. This is mainly used in total shoulder arthroplasty. So other ways to increase your exposure they are, you can do a pectoralis major snip, and one important landmark anatomical structure to remember is the long head of biceps. So in some conditions you can see it may be an obstacle to reduction, or it may be a source of chronic pain in some cases. So here you can see a CT image of a fracture where it is extending the bicipital groove, and intraoperatively you can see that the biceps tendon is entrapped in the fracture site. So in these cases you can do a long head of biceps tenotomy, or you can do a tenodesis to the pectoralis major muscle. So step 4 is the most important step in a Phillows plating, that is the rotator cuff sutures. So the proximal humerus fracture is more of a soft tissue surgery than a bony surgery. So you can use rotator cuff sutures to reduce the rotator cuff fragments. So you should know the displacements. So here greater tuberosity is displaced posteriorly, superiorly and medially by the pull of the supra, infra and the teres minor. Your lesser tuberosity is displaced medially by the pull of the subscapularis. Your shaft is displaced medially by the pull of the pec major and the latissimus dorsi. And your head may be valgus impacted or varus impacted. If it is valgus impacted, it is usually seen in the superlateral aspect, and if it is varus, it is seen usually posterior inferiorly with the varus tilt. So you can apply the sutures, tension band sutures in the tendon bone junction. You can use fiber wires, you can use ethibond, and ultimately you can secure it to the periphery of the plate. So you can see the GT is displaced now. Once you secure it to the plate, the GT is reduced. And what are the steps for reduction? So there are 4 main points for reduction. You should achieve adequate medial hinge. So medial hinge is the most important thing preventing further varus deformity. So you should achieve that, a medial hinge. You should correct the varus or valgus and have a normal neck shaft angle. You should correct the version of the humeral head. I told that there is a retroversion probably. So you should correct the version and achieve adequate sagittal alignment, and you can reduce and secure the tuberosities using your cuff sutures. So in surgical neck fractures, there are only 2 basic fragments. There is a proximal and a distal fragment. Usually the proximal fragment is abducted and distal is adducted. So you can give a lateral push on the distal fragment and abduct the arm. It will reduce the fracture site and ensure that there is an adequate medial buttress. You can check the bicipital groove for the rotational alignment, and you can rotate the arm to align the bicipital groove. In a 3-part varus or valgus fracture, so you first reduce the calcar. then you can correct the varus or valgus. Here you can see a varus displaced head. You can put a lever through the fracture site and you can correct the varus alignment. Here you can see a valgus impacted fracture where you can use same and correct the alignment into varus. And then you can secure with the K-wire and ultimately fix with a plate. Then you reduce the tuberosities by cuff sutures and temporary fixation with the K-wires. Step 6 is medial calcar reduction. So anatomical reduction of the medial calcar is much important in a Philos plate. So your shaft is medialized and impacted to the head. So you should position your plate in such a way that you are able to put a calcar screw in the inferior aspect. So it should be within 5 mm of the subchondral bone. If by any way your medial calcar is lost, you can augment it. So according to the article by Samir Mehta, they say that better place the plate low than high, because if you plate the plate low, it is high chance that you will get a calcar screw in position. According to this image you can see here, if you are placing the plate high, there is high chance that you will miss the calcar, since the third image shows that distal screws will support the calcar. You position the plate correctly. So the plate should be placed 2 to 4 mm lateral to the bicipital groove. I already told you that the vessel arcuate artery is there, so less chance for injury to arcuate artery if you place the plate lateral to the bicipital groove. It should be 8 mm below the tip of the GT. This is to prevent impingement, subacromial impingement. So it should be 8 mm distal to the tip of GT. If the plate is too proud, it can impinge on the acromion and cause subacromial impingement. The first screw usually put in the distal oval hole, and the calcar should be positioned in the infromedially within 5 mm of the subchondral bone. The green screws are the calcar screws. Whenever there is a medial buttress is lost, you should augment it. You can augment by either using a fibular strut or you can augment by using a calcium phosphate cement. So you can see here, first is a calcium phosphate cement and the second image shows a endosteal fibula used to augment the medial cortex. Now screw insertion. So proximal, medial and dorsal parts have higher bone marrow density compared to superior and anterior parts. So you should identify the zones you have better BMD for better screw purchase. So put as many screws as possible, minimum 4 screws in the proximal fragment and maximum screws in the central and the inferior part of the head. You should put at least 1 screw in the inferior aspect, preferably 2 screws, and ensure adequate screw trajectory and at least 3 bicortical screws in the distal part. So the most important complication of a Philos plating is screw penetration. So how to avoid screw penetration? So it can be intraoperative or it can be late. Intraoperative, you may miss it by not taking proper CM views, or late it can happen due to a varus collapse and secondary screw penetration. So it usually happens in the posterior part of the humeral head, which can be seen by taking an AP view in 60-degree exonotation or an axillary lateral view. So how to avoid screw penetration? You can reverse drill the near cortex. You don't drill the subchondral bone. You can use calibrated drill bits and depth probes. You can use screws which are 3 mm shorter than the measured length and usually at least 5 to 8 mm away from the articular surface. And you should ensure that you are taking adequate CM views. So you should take multiplane views. So you should take an AP view in interrotation to see the anterior hemisphere, in neutral to see the middle hemisphere, and in exonotation to see the posterior hemisphere, and axillary lateral view in 30-degree abduction to see the inferior hemisphere and 90-degree to see the superior hemisphere. So to conclude, you should know the parts of a proximal humerus fracture, should achieve adequate reduction with adequate neck shaft angle, medial calcar continuity and adequate tuberosity reduction. Should use cuff sutures to reduce, accurate plate and screw positioning, and you should avoid screw penetration and augment middle hinge if necessary. Thank you.
There is a question. In a 3-part fracture, you told you will lever through the fracture site and try to reduce it. In a severely osteoporotic old lady, this will result in more damage to the bone. Yes. The better method would be, you see the greater tuberosity, but you don't see the head as such. You can do an elective osteotomy of the lesser tuberosity. Convert the 3-part fracture into 4-part fracture.
Can do so.
And then reduce the head and fix it. If you cut the subscapularis, the healing is not good. So you cut it with a piece of bone so that it can be fixed back.
Bone healing.
In short, you are converting a 3-part into a 4-part and fixing it. Rather than working through the fracture site, levering the head, it will result in more and more combination.
Yes, sir.
Also, how many suture bites will you take and in what all direction to secure the rotating surface?
Usually you take bites in the superior aspect, middle aspect and the lateral aspect. You take in subscapularis, supraspinatus and one posteriorly. And you secure it to the periphery of the plate.
Okay. Any more questions to sir?
Another point is if you valgasize the head too much, the sector in which you will put the screws and get the perch will be less. So varus is negative, varus is bad, excess valgus is also bad in pillows. So it should be anatomical. If you put in excess valgus, your upper screws will not have perch in any of the bones. Both are equally dangerous.
Usually you put the first screw in the oval hole, head superior screw. So better to initially only check whether your calcar screw is correct, then you can readjust the plate accordingly. So it is better to aim it a little low so that you can get the calcar screw correctly in the inferior aspect. Yes. Thank you.
Thank you, sir.